Morning, dear guys. So today we'll discuss the topics of infarction and we'll begin the pathology of immunology system. Yeah, we'll start the immunology set of lectures. So today we'll start with the infarction topic. So where we stopped in previous time. Really tough. So I remind you a short introduction. What did we discuss in previous time? We discussed the fate of thrombi. We discussed fate of thrombi. What is a disseminated intravascular coagulation? Very superficially we discussed it, but later we'll discuss in next semester in much more details. We also discussed what is embolism. We discussed what is a pulmonary thromboembolism. We have what is systemic thromboembolism and what is the fat embolism, amniotic fluid embolism, air embolism, and and discuss the summary of this. Okay, and now we continue with the topic of infarction. So infarction is it's a very common disease, and all of you, so even non-medical students, so everyone heard about the infarction. So and then let's talk about this. So infarct is an area of ischemic necrosis caused by occlusion of the vascular supply to the affected tissue. So we discussed in topic of necrosis. Yeah, so necrosis, which is promoted by hypoxia and ischemia. So this infarction is a outcome of ischemia. That's main idea. So here is some part of statistic. Roughly 40% of all deaths in the United States are a consequence of cardiovascular disease, with most of the deaths stemming from myocardial or cerebral infarction. So first of all, when we say about infarction, we think about heart, but infarction might happen not only in heart, not only in brain, but it happens in almost every organ, and now we'll discuss it. So first of all, we'll discuss the morphology of this, how morphologically it happens. So 1 minute, I'll join Sif. First of all, we classify them according to the appearance. So according to the color. So color of infarcts are might be red, white, and septic, or also known as blend. So here we see these examples. So this is red infarction, this is white infarction. So red infarction. So what is a red infarction? Red infarction happens in hemorrhagic way. So when in areas, red infarctions happen in areas with collateral blood supply. So when, okay, let's talk about red infarcts. So they're present as a result of venous occlusion. So we discussed the congestion in previous lecture. Yes, so that congestion is causing the decreased intake of blood through this area, and increase in intake of blood causing, of course, as you remember, it causing the ischemia. And because a large amount of blood is collected in one area, so and that's why red infarctions are usually chronic. They require more time because it's happened due to acute obstruction of veins, but also along with it we have it is correlated with chronic deficiency of oxygen, and that's why in these areas we can find red part of the organ, so where we see the increased amount of blood in this area. So it's typical for lungs, ovaries, and so in small intestine. Also typical because it's typical for areas. So look, you see it's shown here as a result of venous occlusions, for example in ovarian torsion. So in ovarian torsions, and when arterial supply is still present, but outflow of blood, it does not happen because veins possess less pressure, and due to this they easily collapsed, and that's why blood inflow, but influx of blood happens, but outflow doesn't happen. Okay, in loose tissues, so such as lungs, blood can collect in infarcted zones. So then, as this example we discussed before, and also it present in tissues with dual circulations such as lung and small intestine. So when we have blood intake from different sides. So, and destruction of one part is followed with recirculation, so formation of new blood supply to the necrotic area. Okay, and in previously congested tissues, as consequence of sluggish venous outflow, as I said in the beginning, and when flow is re-established after infarction has occurred. So so red infarction, also so part of red infarction is present even in white infarction. So because when white infarction happened, you remember it's injury, it's tissue injury, and due to tissue injuries, so formation of new blood vessels happened. Production of VEGF, vascular endothelial growth factor, and which later formed in the surrounding of blood vessels around the necrotized white infarcts. Okay, let's discuss the white infarcts. White infarcts, it's most common type. White infarcts is a portion of coagulative necrosis, and we discussed it. Yeah, so in very details in practical class we discussed that ischemia in most of organs causing coagulative necrosis, and this is coagulative necrosis, a typical coagulative necrosis. It's present in the heart, spleen, kidney, and where tissue density limits the seepage of blood from adjoining patient vascular beds. Okay, they are wedge-shaped with the occluded vessels, the apex of the organ peripherally forming the base. So what's the main idea? So usually blood vessels supplying this in this wedge shape. Yeah, so in this triangular shape. One artery gives rise to a lot of different collaterals, and if collapsing of artery going on here, abruption of blood supply going here, so every area which is present around is undergoes suffers from ischemia, and then slightly died in coagulative infarction, in the way of coagulative infarction. So this is white infarction. So it is white. I remind you that why coagulative infarctions are usually white. It's happened due to proteins which are present in these tissues. They are getting denaturated, and due to denaturation of these proteins, it resembles the egg white. Yeah. So when egg white um, gets boiled, and it leads to denaturation and became more solid than liquid. So this is typical for white infarcts. Okay, the margins of acute infarcts typically are indistinct and slightly hemorrhagic. Um, with the time, the edges become better defined by a narrow rim of hyperemia attributable to inflammation. So don't forget that tissue necrosis causing the inflammation to this area, causing inflammation, and all these attempts of repair. Just attempts of repair, because it's all of this we discussed. It's blood formation. Blood vessel formation is promoted by inflammation. And due to this, so every infarction area, so even in coagulative necrosis, is surrounded by these blood vessels, and it undergoes a hyperemia, and so it heals us. Sometimes even infarcts can be healed by this, so it can be replaced in some tissues, but in some tissues not. Let's discuss it. Infarcts resulting from arterial occlusion in organs without a dual circulation typically become progressively paler and more sharply defined with time. So, because cells are supplied by specifically this artery, and it has no double circulation, and only this artery is a source of this oxygen and glucose and amino acids and other type of supplements. And of course, that gradually it undergoes necrosis, and that's why it became paler. And after some time, it's easier to identify this area. So extravasated red cells in hemorrhagic infarcts are phagocytosed by macrophages, and the heme iron is converted to intracellular hemosiderin. So it's uh, okay. So it's typical for red infarctions. Yeah, I mean. Small amounts do not impart any appreciable color to the tissue, but extensive hemorrhages leave a firm brown residue. So that's why in some spongy organs, in red infarctions, we have brown areas. So because of releasing of hemosiderin. Okay. In most tissues, the main histologic finding associated with infarct is ischemic coagulative necrosis, as I said in the beginning. Inflammatory response begins to develop along the margins of infarcts within a few hours and usually is well defined within 2 days. And inflammation is followed by repair, beginning in the preserved margins. We discussed it. So, and one idea we discussed it in chapter number 2. So in cell damage, the brain is an exception to these generalizations. Ischemic tissue injury is a central nervous system results in liquefactive necrosis, as I said it before. So it happens due to attendance of a lot of fats in this area and activity of microglial cells in the brain tissues, which facilitate the liquefaction, so destroyment of this. So we have Wallerian degeneration, might be discussed it previously in physiology or histology, and due to Wallerian degeneration, so most of tissues get liquefied, destroyed in a liquid form. So this is this typical appearance. Okay, and infarctus, they happen when a large when infected cardiac valve, for example, they form the vegetations, they embolize. So we discussed the embolization, and this bacterially followed thing, bacterially followed bacteria which is attached on vegetations. They are they obstruct the blood vessel, and of course it's followed with also bacterial invasion to this area. And of course in this case the infarct is converted into abscess with a correspondingly greater inflammatory response and healing by organization and fibrosis. So that's, for example, remote kidney infarct, now replaced by a large fibrotic scar. So you see, it was a kidney infarction, and now instead of kidney tissue, we have a fibrotic scar. So you see, it's must be one branch of kidney artery is obstructed, and that causes a very huge infarction in this area. So, factors that influence infarct development. So, first of all, it's anatomy of the vascular supply. So, if a vascular supply in this area is designed only for one artery, so for example, like here in this infarction, yeah, only one artery supplies entire this infarction. So, of course, it leads to death of all cells which are supplied by this. But you see here peripherally, near the cortex of kidney, we can find some living cells, living tissue, which are not scarified. Because of what? Because if you remember the anatomy of kidney and histology of kidney, here we have arcuate arteries, and which supplies the peripheral part of this. So that way, don't forget about this. So if we have oxygen to this area, if we have blood supply, so it will be survived. Yeah, might be atrophied because of less nutrition to this area, but still alive. Okay, the presence or absence of alternative blood supplies. Okay, I explained this. So in kidney, it's a good example. So because both of them are both present. So when some part of kidney, so usually medulla is supplied by one artery, but cortex is supplied by anastomosis, which are known as arcuate arteries. Okay, rate of occlusion. Slowly developing occlusions are less likely to cause infarction because they allow time for the development of collateral blood supplies. So if occlusion is very fast, so of course, so we have no time to repair it, and of course, it causes the necrosis, very fast necrosis. But in some areas where we have arterioles, so like small interarteriolar anastomosis, they carry minimal blood flow, interconnect the three major coronary arteries, and they can in a slow way. So someone tries to join. Okay, so blood flow interconnects the three major coronary arteries. If one coronary artery is slowly occluded, so for example, by encroaching atherosclerotic plaque, flow with this collateral circulation may increase sufficiently to prevent infarction, even if the original artery becomes completely occluded. So you see, if it's not embolism, but it's just a gradual occlusion, so we have time to arrange this normal circulation. Our body is very flexible, and our tissues can be healed by ourselves, even in very acute pathologic condition. And tissue vulnerability to hypoxia. So, for example, if we compare different cells, neurons, yeah, neurons they get irreversibly damaged into deprived of their blood supply for 3-4 minutes. Okay, 1 minute, sorry. Okay, for example, neurons, yeah, they can after 3-4 minutes of deprivation, so they can irreversibly change and die. So, but if we compare it with myocardial cells, they can survive 20 or 30 minutes with deprivation of oxygen. And that's why if we rearrange, so if we remove the clot, for example, in heart from the heart, so it's irreversibly changed myocardial cells will be decreased in amount, and that's why so we have a I don't know so how it happens in your country, in our country, in acute infarction state. So we have emergency by which we can remove the clot from the coronary artery, and by this we can prevent the severe outcomes of this infarction. So, and then summary infarcts are areas of ischemic necrosis most commonly caused by arterial occlusion, so typically resulting from thrombosis or embolization. And venous outflow obstruction is a less frequent cause. And in venous outflow, so usually it is followed with red infarction. Yeah, infarcts caused by venous occlusion or occurring in spongy tissues typically are hemorrhagic red infarctions. Those caused by arterial occlusion in compact tissues typically are pale or known as white infarction. And whether or not vascular occlusion causes tissue infarction is influenced by collateral blood supplies, the rate at which an obstruction develops, intrinsic tissue susceptibility to ischemic injury, and blood oxygenation. So that's influencing. Yeah, for example, here fibroblasts within myocardium remain viable after many hours of ischemia. So, for example, actually, infarction of somewhere, I don't know, in bone or in some connective tissue, so we can survive after this. So, because so clot can be formed, then and undergo all the process of rearrangement, and finally it can it can be healed. So because oxygen is not so important for the cells, because there are not so many mitochondria, not so large workload to the cells, and that's why they don't undergo some very hard biochemical changes. So not so hard. Not so hard metabolism in the cells happening there that don't require too many ATP molecules. Okay, now finally let's talk about shock. Shock is a state in which diminished cardiac output or reduced effective circulation blood volume impairs tissue perfusion and leads to cellular hypoxia. So please remember this definition, because we used to think shock is something emotional shock. Yes, I'm shocked. Yes, this word expression so confuse a lot of students. So actually, shock is always diminished cardiac output, or might be its reduced effective circulation blood volume. When blood volume is decreased, or actually always in shock we have decreased blood pressure, BPH is decreased, so this is a shock. Everything else is not shock. If we have decreased blood pressure, it's a shock. So at the outset, the cellular injury is reversible. However, prolonged shock eventually leads to irreversible tissue injury, as every condition. Yeah. So if it's not prolonged, so it's reversible. If it is prolonged, so it's irreversible. So, three major types of shocks. So here we need to concentrate our attention on these three parts: cardiogenic, hypovolemic, and septic shock. Cardiogenic, it happens due to myocardial infarction, ventricular rupture, arrhythmia, cardiac tamponade, pulmonary embolism. So you see, in all these conditions, so we have some injury to the heart, and heart doesn't provide the proper function, and that's why, of course, the pumping of blood is reduced, and it causes the failure of myocardial pump, resulting from intrinsic myocardial damage, extrinsic pressure, or obstruction to outflow. So and especially so you will encounter with the myocardial infarction and arrhythmia, so usually they are accompanied so in this shock, and you have to deal with it, so because you can help your patient with this in these conditions. In cardiac tamponade also you can cardiac tamponade, so if you don't remember, so what is cardiac tamponade? It's a condition in which blood appears in a pericardium bag. Yeah, so and it restricts the contraction of heart. And due to restriction of heart contraction, so in cardiac tamponade, so blood cannot enter into general circulation. Okay, then hypovolemic shock. Hypovolemic shock, so it's very easy. So hypo, decreased, volemic, so volume, yeah. So it's a decreased volume of blood when acutely blood circulatory blood is decreased. For example, it happens in hemorrhage most commonly. So if you see that your patient in shock, but he is very young and has no any kind of other signs, so you have to check him for innate bleeding. Okay, and also fluid loss, not very common. It's caused by vomiting, diarrhea, burns, trauma, and usually accompanied with other symptoms. So, and you can confuse it. So, of course, in hypovolemic shock, you can help your patient. So you can heal them with the injection of more liquid, and injection of RBCs. RBC transplantation, yeah. So blood transfusion. So in this condition, you must to help your patient. You shouldn't leave this patient in hypovolemic shock. So in this, if you have hypovolemic shock, death due to hypovolemic shock, so it's your fault as a doctor, because we didn't make something, so and you could help your patient. Okay, and septic shock. Septic shock is overwhelming bacterial microbial infection, gram-negative sepsis, gram-positive septicemia, fungal sepsis, or super antigens. For example, in toxic shock. So this, and we didn't discuss the anaphylactic shock in the today lecture, so we will discuss it in immunity diseases, but it also happens. So in septic shock, we'll discuss the pathogenesis of septic shock a little later, but generally peripheral vasodilation. So you remember that in inflammation we have particularly in some tissue of in some part of the human body, we have vasodilation. But in sepsis, so when bacteria are present all over the body, they are spread all over the blood circulation, and it causes inflammation in every small circulation part, and cause the peripheral vasodilation all over the body. And of course it causes the it's actually this also can cause the peripheral vasodilation. It causes the same event as happened in hypovolemic shock, but all this liquid, so it's not released somewhere outside, yeah. So it's not due to bleeding, but due to exudation of plasma into the peripheral parts of the body. And also so in pooling of the blood in peripheral organs, because arterial and venous are a little uh, dilated. So also it caused by endothelial activation injury. So sometimes some septic shock, so causing the endothelial activation or injury. So, and also we have leukocyte-induced damage. Leukocyte-induced damage, so it's additional reason. So we'll discuss it. And disseminated intravascular coagulation, as I explained it before. So when all the blood vessels are coagulated, so so you remember that inflammation also promotes the coagulation cascade, and we will discuss it. So we already discussed it, and then we will continue discussion of this in infection diseases. And also activation of cytokine cascades. This condition is known as cytokine storm, and it causes a lot of changes, which finally leads to decrease of blood pressure. So pathogenesis of septic shock. Let's discuss the pathogenesis of septic shock. So here, if I'm not mistaken, we have diagram. So these diagrams need to be very well understood. So you see, we have microbial products. So when too many microbial products are present and they reach even into the blood, it causes endothelial activation. All the time they cause the endothelial activation. And along with it, microbial products cause the activation of neutrophil and monocytes in the blood, and also it causes a activation of C3 complement. You remember this in every of this in lectin pathway, in alternative pathway, in classical pathway. So it doesn't matter. C3 is splits and forming the C3b and C3a, and the C3a causing the recruitment of more neutrophils and leukocytes. It promotes the inflammation. They also take part in promotion of inflammation, and also microbial products causing the factor 12 activation. So you remember it's extrinsic pathway of platelet aggregation in our process of coagulation. Okay, let's start with endothelial. So what caused by neutrophil and monocyte activation? Neutrophil and monocyte activation start to produce cytokines like TNF, interleukin 1, and HMGB1. So these mediators, cytokines are, and cytokine-like mediators, they cause in the activation of cascade of reaction. So one of the main is the systemic effects. It causes the fever, diminished myocardial contractility, metabolic abnormalities. You remember that fever, so causing the vasodilation all over the body and causing the systemic effect. Okay, also it causes activation of interleukin 10 and apoptosis. So, and fast apoptosis of a lot of cells, so causing the releasing of secondary anti-inflammatory mediators, and it also causes immunosuppression. So over-tension of immunity system, so causing the activation of anti-inflammatory mediators, which causes the immunosuppression, which also promotes the shock. Okay, then let's talk about factor 12 we discussed. So it causes coagulation. It causes the microvascular thrombosis, which is known as disseminated intravascular clotting coagulation, disseminated intravascular coagulation, and it causes a tissue ischemia in a lot of organs, which finally causes multi-organ failure. And also one of things we used to forget, it's the tissue ischemia causing the ischemia in adrenal gland. And you remember adrenal gland producing the adrenaline and cortisol, and both of them are so especially catecholamines, which are produced by adrenal medulla. They are maintaining the blood pressure, and the adrenal insufficiency, which caused by this, causing the dropping of blood pressure. It is it is a pathogenesis of septic shock. Okay, so another activity, so endothelial activation, so most complicated part. So how endothelial activation causes the shock? So first of all, endothelial activation so might cause the procoagulant factors increased, and decreasing of antithrombotic factors like TFPO1, thrombomodulin, and protein C. Also antifibrinolytic activity so increased, but it so antifibrinolytic. So why it's increased if it's decreased? Okay, anyway, so it causes the microvascular thrombosis, And also, along with the endothelial activation and macrophage and leukocyte activation, it causes the releasing of interleukin 6, interleukin 8, NO, puffs, and reactive oxygen species. And all of them are commonly causing the vasodilation, increased permeability, and decreased perfusion. And all of these events finally causing the one thing. So decrease the blood flow in every organ, in most organs and life-threatening organs. And due to this, it's called the multi-organ failure. That's why and usually patients died in every of these conditions. So even in hypovolemic shock, in cardiogenic for shock. So patients died with multi-organ failure. So because finally um, all the organs get collapsed. So stages of shock. Okay, dysfunctional discussion. Okay, I hope you know it. Stages of shock. Any shock, so it has initial non-progressive stage during which reflex compensatory mechanisms are activated and vital organ perfusion is maintained. So it seems like everything is normal, but some clinical manifestation is started. So then progressive stage, it characterized by tissue hyperperfusion and onset of worsening circulatory and metabolic derangements, including acidosis. So it causes the decreased perfusion and acidosis. So it's beginning. It's a still reversible thing, but in a reversible stage in which cellular and tissue injury is so severe that even if the hemodynamic defects are corrected, survival is not possible. So that's of course in this condition patient dies. In the early non-progressive phase of shock, various neurohormonal mechanisms help maintain cardiac output and blood pressure. So that's we discussed. And net effects. So 1 minute. Okay, let's continue. Net effect of tachycardia, peripheral vasoconstriction, renal fluid conservation. So cutaneous vasoconstriction causes the characteristic shocky skin coolness and pallor. So it's typical septic shock can initially cause cutaneous vasodilation. So the patient may present with a warm, flushed skin. So that's remember this clinical feature. Um, okay. So anyway, so let's talk about morphology. Uh, So the cellular and tissue effects of shock are essentially those of hypoxic injury and are caused by a combination of hyperperfusion and microvascular thrombosis. Any organ can be affected. The brain, heart, kidneys, adrenals, and gastrointestinal tract are most commonly involved. Fimbrium thrombi can form in any tissue, but typically are most readily vascularized in kidney glomeruli. Visualized, of course. Adrenal cortical cell lipid depletion is akin to that seen in all forms of stress and reflects a decreased use of stored lipids for steroid synthesis. Whereas the lungs are resistant to hypoxic injury in hypovolemic shock occurring after hemorrhage, sepsis, or trauma can precipitate diffuse alveolar damage. So you see, it's a polyorganic shock morphologically. We see it's known as shock lung. Except for neuronal and cardiomyocyte loss, affected tissues can recover completely if the patient survives. So that's why fight for your patient. So always, even in shock condition, you in some situations you can heal them, so heal your patient. That's why don't give up if your patient uh, get this. Shock, so you almost can heal him. Only you need to care about brain and heart. So because irreversible changes of heart and brain, so always causing the death. So clinical features is for clinic. Let's talk about summary. Shock is defined as a state of systemic tissue hyperperfusion resulting from reduced cardiac output and or reduced effective circulation blood volume. The major types of shock are cardiogenic, hypovolemic, and septic. Also here is not explained is, as I said, this shock, allergic shock, so also known as anaphylactic shock. Anaphylactic shock. Shock of any form can lead to hypoxic tissue injury if not corrected. Septic shock is caused by the host response to bacterial or fungal infection. It is characterized by endothelial cell activation, vasodilation, edema, disseminated intravascular coagulation, and metabolic derangements. So now we'll shift to the another part. So now we switch to another topic. It is known as disease of the immune system, and here we have to understand the normal immune response. Of course, in physiology and histology, you didn't discuss it in such details, so that's why now we have to understand the normal immune response activity. And in this lecture and in next lecture, we'll discuss only normal situations and with little correlation with pathology. But finally, in the end of this set of lectures, we'll discuss the other pathological events. So,
Excuse me, sir.
yeah.
Okay.
Okay, next part of a lecture will continue next time. Tomorrow we have a lecture and we'll discuss the immunity again in details. So, because you're tired. Thank you for attention. So, don't forget to write your name. See you next time. You can leave.
Thank you.